Well, good morning, everybody, and welcome to our virtual journal club. Thanks again to the Seattle Spine Foundation for sponsoring this, as well as our co-host from TBI. Today, I've got a group from UCSF, and we're going to talk about some issues of healthcare economics, and specifically some appropriate use criteria and considerations of the appropriate use of surgery for managing spinal disorders, and some consideration of value and payment models and how payment models have really affected care and how effective they've been in controlling some of the costs of care. Many of you are familiar that we did one of our case series was about a series of cases that had some interesting economic considerations with regard to contribution margins for the hospital and with regard to access to care and health insurance. And this will be more of a literature-based consideration of some of the same issues. I'm going to start here with just a couple of slides, or maybe about 10 minutes, on some healthcare economic considerations. And then our overview is going to be my introductory talk. We've got Tim Lockney, who's one of our neurosurgery fellows. He's going to talk about appropriate indications for surgery. Andrew Lee is going to talk about how multidisciplinary panels may affect utilization of lumbar surgery and rates of surgery. Mike Venezia is going to talk about bundle payments and the effect of bundle payments on care for lumbar fusion. And then Kevin Hindian is going to talk about accountable care organizations as another payment model and how that's really affected complications and readmissions. So that'll be our outline for today. I'm going to try and give a good amount of time for those cases or those articles to be presented. So the overview then, we're going to talk a bit about some appropriate use of care in spinal disorders. And I think it's important to recognize here that perspectives and incentives are sometimes different between the payer, the surgeon, and most importantly, the patient. And a lot of that has to do with risk and how much risk one might be willing to accept. And also expected benefit, of course, that drives appropriateness. We'll talk about multidisciplinary panels. And again, this has to do with perspective and the observation that if we involve primary care physicians and anesthesiologists in decision-making, there may be significant differences in our perspective on appropriateness of surgery and on rates of utilization of surgery. And finally, healthcare reform is how do alternative payment models actually affect providing care in terms of quality? And we've got two articles that address that, both an article looking at experience with bundle payments by Brooke Martin and an article looking at within the context of an accountable care organization, how does that affect providing spine care? So again, I'm just going to go for a brief overview to give a little bit of background for those of you who might not be familiar with some of the concepts. And the notion of appropriate care for patients, we do a lot of work with complex deformity, but degenerative pathology and all of spine, what's appropriate? There's a broad spectrum of interventions we can have for any case, ranging from non-operative interventions to decompression alone to decompression with more limited fusions to really rather extensive reconstructions. And I think that appropriate choice and defining an informed choice needs to be based on valid information regarding natural history. So, for example, somebody with severe cervical stenosis and early symptoms of myelopathy, or somebody with a progressive deformity. Also, valid information on the expected outcomes of care, expected outcomes in terms of change in health quality of life, and the expected risks of different care options. One of the areas that we've contributed to has been the use of appropriate use criteria. And the notion here of appropriate use is that an appropriate operation fundamentally is an operation in which the expected benefits exceed the expected risks by a wide margin. And the corollary, of course, is that an inappropriate surgery is an intervention in which the appropriate risks exceed the expected benefits. And oftentimes, this perception of risk and benefit may be different from the perspective of the surgeon versus the patient versus the other party involved in a risk is the healthcare system. So what are the real drivers of appropriateness in surgery? We've done a bit of work on this now, and some of this work has involved the RAND group. And we found that in adult deformity, some of the real drivers of appropriate have to do with the severity of preoperative symptoms, whether or not a deformity is progressive or if it's stable. Sagittal alignment was a big consideration, and also the comorbidities of the patient. And to that end, we went through a whole series of cases with a multidisciplinary panel, and those are the primary considerations with regard to whether or not surgical intervention was appropriate. And then the question became how extensive a surgery to do. We also did another multi-center study where we looked at appropriate evaluation of patients with deformity. And we looked at what's appropriate for preoperative goals and preparation of patients, what are some intraoperative strategies that are appropriate, and what about postoperative management. And it's interesting to see some of the diversity here with regard to what's expected in terms of preoperative preparation and intraoperative strategies. Ultimately, appropriate care is a balance of the risks and benefits and an understanding of what the alternatives are. And one of the things that gets in the way, I think, sometimes of decision-making and behavior is the notion of moral hazard. And again, if appropriate decision-making is based on some balance of risk and benefit, well, sometimes the parties involved may not perceive the risk and benefit equally. And the classic examples there are the mortgage lender in the banking system, where the mortgage lender might not actually face the risk of a failed loan, and that really led to our housing loan crisis. Because if the mortgage lender knows there's going to be a bailout, and it involves a lot of areas of insurance and medicine as well. And in medicine, I often talk about George Bernard Shaw, who was the 19th century socialist that started the London School of Economics and also a playwright. And George Bernard Shaw wrote about the doctor's dilemma, and specifically the notion that the doctor is disassociated from the risks of surgery, and that sometimes decision-making may be inappropriate when a physician is put in a situation of being both the judge as well as the executioner. It gets into the notion of preoperative preparation and what risk are we willing to take. And this is one of the preoperative, the preoperative preparation we do at UCSF. We look at blood sugars, bone health, obesity, nutritional status. And in general, most of us will try and avoid surgery on patients with a hemoglobin A1C more than 7, patients who are osteoporotic, patients with a BMI more than 35, patients who are malnourished, patients who are actively smoking, patients who are using more than 50 milliequivalents of morphine per day, patients without adequate home support, patients who are frail. My partner, Dr. Birch, has done a lot of good work on frailty, patients with untreated anxiety or depression. So recognizing these as major risk factors are important. But at what point, if your OR schedule is not full, do you think, well, hemoglobin A1C of 8 is really not that bad, a BMI of 40, well, maybe that's an appropriate place to do surgery. An active smoker, well, I think they'll probably fuse if I use BMP, et cetera. So I think that sometimes surgeons may actually be incentivized to be more risk prone than healthcare systems that are at risk, or than patients may be willing to be risk prone. So again, a lot of variability in how we approach common spinal pathologies, and how do we make informed choice in scenarios where there may be clinical equipoise. And this was really the subject of some of our cases last time around. But sometimes financial considerations come into that. And certainly the TBI group has talked a bit about the financial considerations with regard to doing a disc replacement versus a fusion, and some of the perversities of reimbursement. Similarly, in somebody with a stable degenerative spondylolisthesis, doing a circumferential fusion versus a decompression alone, there are financial considerations that come into that also may create significant perverse incentives. And one of our articles will deal with that. To that end, to some extent, with spine surgery, we've got multiple disciplines involved. So we've got spine surgeons, of course, non-operative spine specialists between anesthesiologists and physiatrists, physical therapists, radiologists, neurologists, primary care physicians. So there's a lot of specialists involved. And putting those specialties together, the boys in the boat, those of you in Seattle, recognize this as being the University of Washington team back in the 1936 Olympics. And putting those specialties together really creates a special blend. And I think it's awfully important to get the perspective of the multiple providers who are involved in a patient's care. And I think that when we get multiple providers involved, multiple specialists involved, that actually might change significantly our utilization of care. And that's background to Raj Sethi's article on utilization of care after multidisciplinary panel consideration. The final topic we're going to talk about today in the articles is reimbursement reform. And so is reimbursement reform, as we think about alternative payment models, is this us heading headlong into some type of a tsunami, or is this actually a utopia that we're heading for? Bob Mecklenburg, who's up in Seattle as well, he's recognized that 50% of private healthcare expenditures are from employer-managed plans. And right now, I think employers have a terrific capacity to choose the best providers, to cap prices, and below this, that's not shown in the slides, is to demand quality as well. Bob Kaplan we had as our visiting speaker recently in a NASP panel, and Bob Kaplan outlined two major alternative payment models that are alternatives to our current world. So our current fee-for-service world, we talked a bit about in our case presentation recently, and our current fee-for-service world really does drive a lot of inappropriate care because, again, in a fee-for-service world where there's clinical equipoise, the tendency is oftentimes to go for the more expensive procedure, even though a less expensive procedure may be equally effective. Well, in alternative payment models, there's the notion of sharing risk, and both in bundled payments, when we look at the cost of care for the overall episode of care, extended to 90 days or in some cases even longer, and then accountable care organizations. So accountable care organizations involve population care, where really we're accountable for the care of the patient over the course of a lifetime and for the total cost of care. And we have a capitation system such that suddenly perhaps the most expensive procedures aren't the most appropriate procedures. And again, sharing risk. The fundamental notion of these alternative payment systems of transitioning from fee-for-service to accountable care involves offloading risk from the payer to the provider. It involves some shared responsibility, and in many cases, alignment of goals for the hospital and the physician. So again, we all recognize a lot of situations where the physician goals are very different from the hospital goals. The hospital might be looking at contribution margins and some quality metrics. The physician, I think, always puts patient interest and quality first, but also has different reimbursement models. Also, the patients suddenly are confronted with financial risk, and there are tiered insurances and networks that may drive patients towards cheaper options. And that's true both in bundled payments, which we'll hear more about, as well as in alternative care models. So one of our papers is this paper by Brooke Martin, look at some of the early effects of Medicare's bundle payment. And I'm going to let that be presented by one of our fellows instead of going through this. But the summary right now in terms of bundled payments is that it's been very effective for some of the joint replacement procedures. It's also been very effective for some cardiac procedures. But in spine surgery, there's a lot of variability to the cost of spine surgeries. And at this point, the effectiveness of bundled payments in spine procedures has really been quite mixed. And indeed, the improved quality as well as cost hasn't been well demonstrated in some systematic reviews. So that was just a background that I wanted to start with to give everybody some understanding of what alternative payment models are, what bundle payments are about, what accountable care organizations are about, what appropriate care and appropriate use criteria is about. I think fundamentally, in all of our discussion of healthcare economics, we've got to go back to the work of Francis Weld Peabody. And many of you recognize that Dr. Peabody was a physician back in Boston in the 19th century. And he wrote The Art of Care and Caring for the Patient. And he said that one of the essential qualities of the clinician is interest in humanity, and that the secret of care of the patient is to actually care for the patient. And I think that keeping patients centered in consideration of all of these economic models is really the priority. And that's, I think, what makes the physicians different than the financial analysts. So with that as a background, I'm going to give the screen up to our first presenter. And our first presenter is going to be Dennis Lockney. Dennis is one of our new fellows coming on at UCSF. Dennis came from Florida. He's trained as a neurosurgeon, and he's working primarily with Berven Mubaneni, but also doing quite a bit of work with our orthopedic spine group here as well. And Dennis is going to talk about how do we really measure appropriateness of care for surgery. So go ahead, Dennis. Tim, I should say. Dennis goes by Tim.
Yeah. Thanks. Sorry, I like to confuse people. Sorry, I see I misspelled your name there. I'm not sure how that happened, but anyway, good morning. Thank you for that excellent introduction. Happy to be part of this journal club today. Oh goodness.
Dennis, go ahead and tap the screen with your. There
we go.
You got control.
Okay. So anyway, can you guys hear me all right? Good. Yep. I'll be discussing this paper called The Appropriateness of Indications for Surgery in Lumbar Disc Hernia and Spinal Stenosis. This is a paper that was published in actually 1997. So what this paper was, a brief overview, is a prospective study of 328 consecutive patients that underwent lumbar decompressive surgery between 1992 and 93 in Switzerland. They studied 2 neurosurgical departments at 2 different hospitals in a university setting. The goal of this was to assess the appropriateness of surgical indications for people undergoing surgery for herniated discs or spinal stenosis. They used an American appropriate criteria that was proposed by a panel of experts in 1987. So they measured 1-year outcomes only from one of the hospitals via a standardized interview. And ultimately what they found was that about 38% of surgery indications were inappropriate. 62% were what was called appropriate or equivocal. And ultimately, 74% of patients had a good or very good outcome at 1 year. So just to go into it a little bit more details, the goal of this, every physician, as you know, is to either maintain or increase the quality of care we deliver to our patients. As you noted, there's been a wide variance in the use of laminectomies geographically, and these procedures can have failure rates of up to 30%. So the authors of this study suggested the key to avoiding that failure of up to 30% is in patient selection, or another way of saying that is the appropriateness of indications. So what is appropriate? The expected medical benefit exceeds the risk, and how's it measured? So in the study, they used a method via the RAND Corporation criteria, and we'll go into that. So as I mentioned, 328 patients consecutively analyzed between 1992 and 3. They collected the data preoperatively and postoperatively via standardized interviews, and then determined the appropriateness based on these RAND criteria. So the RAND system works as they review the literature as a basis for all the indications for a procedure. And then the clinician panel develops this mutually exclusive and specific scenario for each procedure based on patient histories, previous treatments, radiology findings, etc. They convene a multidisciplinary panel and review the scenarios and then score them as 1 to 3 being inappropriate, 4 to 6 being equivocal, or 6 to 9 being appropriate. They ultimately developed 219 scenarios for lumbar decompressive surgeries. This is an example of one you can see at the top. They found that if you had pain in your lower limb, imaging positive for disc herniation or stenosis, minor neurologic findings, and restricted activity of 6 or more weeks, they deemed that as appropriate. So they applied one of these clinical scenarios to each patient, and for the analysis, they actually dichotomized patients as inappropriate or equivocal, or for appropriate. They performed a bivariate statistical analysis and then performed these 1-year follow-up interviews, again, only at one hospital. So the results, they had 61% of the patients undergoing surgery were male. The ages ranged from 17 to 85 with a mean age of 47. 49 of those 219 scenarios were actually encountered in their patients, and ultimately 7 of those accounted for about 2/3 of the patients undergoing surgery. You can see most patients presented with back and leg pain, weakness that had progressed, and then almost everyone tried some type of preoperative conservative management, including simply just NSAIDs or other analgesics. And then lower down, we'll talk about this severe activity restriction. 291 of the patients underwent that, or 89%, lasting up to a month, about 50% of the patients. And then again, these are the 7 common clinical scenarios, and the top in the top box, all of these scenarios were considered appropriate or equivocal, and then below were considered inappropriate, and then the other indications, there was a mixture of them as appropriate, equivocal, or inappropriate. So 62%, as mentioned, were appropriate or equivocal, and 126 of the patients, or roughly 40%, about 38, were inappropriate indications. Now, 77 of those patients were deemed inappropriate for a single reason among those categories, and 66 of those were simply secondary to insufficient duration of preoperative conservative management, mostly related to severe activity restriction. They found no association between clinical or demographic variables and appropriateness. So Table 3 just demonstrates that. Their analysis found no association between appropriateness of surgery and demographic or clinical variables based on sex, age, nationality, pain, number of previous treatments, etc. And then Table 4 shows the 1-year follow-up. and basically indicates that there was no specific correlation with the level of appropriateness and how well somebody felt at 1 year after their operation. So that sort of begs the question: 38% inappropriateness. That seems very high, and so that makes us wonder: well, are these criteria valid? And there's some criticisms of how the criteria of appropriateness are developed, meaning what specialty mix helped decide, is it an anesthesiologist being involved? Is it a surgeon being involved? If you have a hammer, is everything a nail? So the specialty mix of the panel which developed these criteria. And then cultural influences can vary between different cultures, what they feel is appropriate risk or inappropriate risk. Certainly changes in practice, and the authors commented on this, duration of activity restriction. Some felt that patients should be bedbound for essentially a month before being offered surgery. I just finished my training, and I don't think I ever suggested somebody with a disc herniation lay in bed for a month. And also, if you excluded that from the analysis, the inappropriateness levels actually halved from 38% to about 20%. So it underscores the need to keep and update the criteria frequently. And then the application of these criteria to these patients. These criteria in the panels are reviewed for an average patient, for a system of healthcare. But what about the individual patient in front of you in your office? Extenuating clinical circumstances weren't evaluated this, and certainly if they were, the amount of inappropriateness would likely decline. 26% of the patients felt that unfavorably about their operation. The authors concluded that they could find no good clinical predictors predicting which patients would be happy with their operation, really underscoring the difficulty of identifying these to help predict good outcomes. There's no association with the level of appropriateness and outcome, but the authors warn and cautious against the erroneous conclusion that because there was no association with the level of appropriateness and the outcome, that invalidates the criteria. That the study was not designed to evaluate that at all. It only juxtaposes patients undergoing surgery for appropriate or inappropriate conditions and describes that these two groups should not be compared. There's some limitations of the study. Certainly there's bias. All of these patients were surgical patients. They didn't talk about non-operative patients. There's no control for that. The outcomes were only studied at one hospital, so we may not know the true outcomes. And then the outcome measures were basically a phone call saying, hey, are you happy you had this operation or not? They didn't use these standardized sort of patient-reported outcome measures that we frequently use, such as the numeric rating score for back and leg pain, as West Street Disability Index, the EQ-5Ds, SF-12, et cetera. I had to look up and see when those were actually around, and they were around for this during the time that this study was formulated and presented. So I presume they could have used them, but they didn't. And so that's pretty much this paper, and happy to open up to any discussion.
Tim, thanks for presenting that. And the reason I chose that paper, it's a bit of an older paper, but most of you are familiar with the literature on healthcare economics and some of the articles coming out from the AHRQ as well as from the Institute of Medicine. This is an oft-cited article that I think needs some consideration. This notion that 38% of patients of spine surgeries are inappropriate is something that's been frequently cited. And I think the background on that, really looking into that in detail, suggests that's probably not the right criteria. Specifically in patients with disc herniations, I think oftentimes early surgery, especially in patients with a neurologic deficit, is appropriate. So I think that this article needs to be discussed, and to some extent, I think it needs to be eliminated from the literature. The question becomes, how do we measure appropriateness, and how do we say, well, indeed, all the surgeries done at the Seattle Spine Group, or all the surgeries done at TBI, or all the surgeries done at UCSF are appropriate? And that remains a bit of a challenge. In some of our interdisciplinary case conferences, we've actually used the RAND criteria and had specialists from other disciplines and had our own fellows, our own attendings evaluate appropriateness using that RAND criteria, the sort of 1 through 9, where 9, the expected benefits exceed the expected risks, 1, the expected risks exceed the expected benefits. In a lot of cases, end up in the yellow zone. And in the yellow zone, I think what takes predominance is the patient's preference and the patient's risk understanding, and really making an informed choice. And that's why sometimes just looking at x-rays alone only tells part of the story. But I'd like to open that up to discussion from others. I see Jens had a couple of comments in there, and but how others rate appropriateness of surgeries.
Sig, I think the point you made is great. It depends on your definition. And I think what this article highlighted is maybe the definition that you must have a certain amount of conservative care is incorrect when the violators had outcomes that were largely quite good. And I think, if you polled many spinal surgeons who have had a large disc herniation with severe sciatica, a good deal of those have opted for early surgery rather than prolonged conservative care, a documented failure of 6 to 12 weeks, and then the surgery. So perhaps it's a definitional issue, and I agree with you that this should not be cited in the literature, but it often is by the people who can make a point by sort of misquoting it. So thank you for including that article.
But, Sig, it's very interesting because years ago, way before bundle payments we were mentioned, we had looked at nearly 100 of our herniated disc patients that underwent surgery because we were considering doing a bundle payment, going to the insurance company and saying, we will guarantee your surgery. So when we looked at our data, we only had an 85%, successful rate. And, you think allowing this to do perfect. So it shows that here is a simple problem that we have been, vexing over all these years, and there are a lot of decision-making properties, and that's why we need really good data that says that, hey, you need leg pain, you need to have a neurologic deficit, you need a straight leg raising, you need to have a correlating x-ray, and you need to have an appropriate amount of care. But the question is, what Jack said, what's appropriate? If you're miserable and you can't move for a week laying in bed, then, that's appropriate. But on the other hand, many patients do get better, and I'll tell you, just in the COVID crisis, I've had several patients with big herniations and we couldn't get them into the hospital. When they come back, they say, you know what? I'm actually doing a lot better now. So, it's a simple problem, but really a complex treatment problem as far as determining, when's the best time, that these patients should be operated, because I think this is one of the most abused operations among the general spine community.
I think it's important, Rick, that the patient's got to be primary to the consideration. Ultimately, of all the stakeholders involved, you've got the payer, you've got the hospital, you've got the physician, and then you've got the patient. And the two stakeholders that really have the most skin in the game. You've heard me talk before about the idea of being the pig versus a chicken contributing to the breakfast, right? The chicken makes a contribution to the breakfast. The pig is the one who really makes a commitment to breakfast. And we're the pigs in the game, right? We and the patients are the ones that have a commitment to what's going on. And that's why I think we've got to be very careful about appropriate use criteria, about some of the DRG-based type systems, and allowing patients or allowing payers to be too involved in the decision-making, because ultimately they're not the ones with the skin in the game. And I think that if we get too regulated with regard to with regard to the rules of who goes to surgery, we get disassociated from the patient's experience. And I think that's a real problem. So let's go head on to the next article. The next article is really going to be about multidisciplinary panels, and I think, is it the next one, multidisciplinary panels? And Andrew Lee is going to talk about how utilization of surgery is different in multidisciplinary panels. So is that right, Andrew?
Yes, sir.
Multidisciplinary evaluation, maybe changing utilization of surgery rates for spine surgery. And just briefly, Andrew is one of our fellows who's going to be finishing this week or next week. Andrew's done a terrific job this year. He's going off to practice in the Central Valley of California, so he'll be local to us and a terrific resource in the years to come.
Thank you, Dr. Berven. So my study is a multidisciplinary evaluation leading to decreased utilization of lumbar spine fusion. This study was performed at Virginia Mason Medical Center in Seattle, Washington, with the primary author, of course, being Dr. Sethi. Just as a brief introduction, the treatment plan for degenerative lumbar spine is often up to a single spine surgeon who makes all the operative and non-operative decisions. And we know that the benefits of shared decision-making in degenerative spine surgery has been extensively studied and demonstrated. However, we do know that some surgeons, unfortunately, largely practice without direct communication with other non-surgical providers. Overutilization of surgical procedures such as imaging have been shown to decrease after implementation of multidisciplinary pathways without a decline of patient outcomes. And in recent history, increasing pressure from payer groups to restrict spine surgery access and expenditures due to increasing costs. So the primary purpose of this study was with required weekly multidisciplinary conferences to review lumbar degenerative spine conditions. This study hypothesized that by forcing direct communication among local content experts in lumbar degenerative conditions, that it could lead to changes in treatment plan when compared to external surgical providers, and to determine the impact of a multidisciplinary conference on treatment decisions for lumbar degenerative spine disease. This study, of course, was approved by an RB, where it retrospectively reviewed cases at a weekly multidisciplinary conference, which included patients who had 3 criteria. 1 was scheduled to undergo surgery involving up to 3 levels of fusion, recommended up to 3 levels of fusion at another institution, came to the MMC for a second opinion, and 3rd, presented with unusual spinal pathology that required a multidisciplinary approach for diagnosis or treatment planning. A quorum of 10 providers at a minimum were involved, including at least 1 provider from PM&R, anesthesia, neurosurgery, orthopedics, nursing, physical therapy, and social work. PAs and NPs were also present, so there's quite a posse there. Each provider was given an equal voice and vote in the decision-making process for every patient. This multidisciplinary conference, of course, was held once a week in the morning, and providers used selection criteria to determine the appropriateness of each patient for presentation at a spinal conference. Consulting physicians presented the patient's case at the conference and discussed assessment of patient, any treatment recommendations made at other institutions. The consensus opinion was then reached by the group on how to proceed with the care of the patient, and the opinion was recorded in the EMR. Breed criteria was utilized to judge various patient-specific parameters and required assessment of disability despite non-surgical therapy and patient fitness for surgery. The group made a decision whether or not to offer surgery. The consulting physician then conveyed the group's consensus to the patient. As shown in this flow chart, between November 2015 and August 2016, 137 patients were presented at the conference, where 100 patients with recommendations for lumbar spinal fusion by an outside provider were evaluated. Of those, from this conference, 58 patients were recommended non-operative management, whether it was physical therapy, ESIs, vertebroplasties, or just bariatric surgery. 42 of those patients were recommended operative management. The average age was 60, roughly 52% were female, 80% were in the state of Washington, 58% had physical therapy, and 70% did undergo epidural steroid injections. Statistical analysis was performed as such, and as a result, the most common present diagnosis among patients who had been recommended for spinal fusion was spondylolisthesis. Lumbar stenosis with claudication or radiculopathy was second most common, with degenerative disc disease being 3rd. As shown in this table too, of the 100 patients that were initially operated, this conference was able to whittle down the operative candidates 42, while they recommended 58 being non-operative. The reasons for recommendation for non-operative management were misdiagnosis, whether it's hip pathology, morbid obesity, active smoking, or they just thought that physical therapy or epidural steroid injections, which would serve much more benefit to the patient than surgery. In addition to surgical recommendations, how they performed surgery was also a matter of a debate as well, on whether it was an inner body or decompression. That also had some variability amongst providers, which I thought was interesting. The final approach management at VMMC, 58% of course were non-interventional management in the majority, rather than surgical management. So as a discussion, it's important to distinguish patients who are likely to see improvement after operative treatment from those treated best with non-operative management. We know that clinicians' biases are based on heuristic tendencies, resulting towards procedures or testing. Multidisciplinary conferences are commonly utilized in other fields, and spine may serve as a forum as well for difficult cases, but also to help standardize care in other outlier events. Like Dr. Berven was mentioning, it's important to capitalize on the wisdom of crowds. Multidisciplinary spine conference serves the same function as a tumor board, to review a patient's history, examine imaging, and also determine a plan of care. As shown in this study, they showed a 58% reduction in spine surgery, shown with the multidisciplinary conference. Some limitations from the study: long-term outcomes were not known for these set of patients, and they did not have information on patients who recommend non-surgical option if they return to the original surgeon. And of course, selection bias: patients present an institution for second opinion. In conclusion, multidisciplinary evaluation can alter the treatment recommendations for patients with lumbar spinal pathology. Isolated surgical decision-making may result in suboptimal treatment recommendations. Multidisciplinary approaches will be essential to optimizing operative and non-operative care for patients with degenerative lumbar spine disease and may ultimately lead to a decrease in the overutilization of lumbar fusion. I can see that we have some questions and some debate that's coming on, so I open the forum for everyone to discuss on this paper.
I'll just jump in with one quick comment. I noticed in the chart they had in the non-operative care, they had vertebroplasty listed as one of the non-operative options. And I just wonder and would like to hear comments, where does operative versus non-operative intervention cross the line? There are many physiatrists who are now in the community who are doing lumbar decompressions with the mild or mild procedure. Again, we're seeing this blurring of operative versus non-operative, and I was interested that they added a vertebroplasty component in non-operative, which I consider an operative intervention.
Izzy, you've opened up a whole nother bowl of wax. I think the point here is that you get more eyes on a case, and just like at TBI, Sig, and the rest of you folks, we have a peer review committee of 5 docs, and we use similar criteria, greater than 3 levels, obesity, whatever. And oftentimes, there is a difference of opinion, and we may recommend, some other tests to be done or some alternative treatment. So I think it is a good idea. It's like anything else. We all get tied up and, it's almost, we can't see the forest through the trees. You get so close to a patient. And a lot of times our physicians or our surgeons are happy that say, oh, I'm so glad you said that because, I was really concerned about that. So I think it is a good idea. The problem is it's time consuming and, obviously a multidisciplinary approach I think is better than just having spine surgeons like what we have. But, again, it's a matter of time. And I think it's the right way to do things if you can institute it. Does anybody else do it? Any other institutions do something similar?
Yep. So Rick, I'm really interested in hearing more details about how you do it at TBI. So at UCSF, we've got actually 2 conferences. Every Monday morning, we go through all the orthopedic cases. And I often say that that's the most important thing I do in my week is Monday morning, hearing from my partners about the upcoming cases. We review all the cases for the upcoming week. And it's no shorter than maybe 20% of the time. I might actually significantly change my plan based on what I hear from my partners. And we also do a Wednesday conference. It's more of an interdisciplinary. It's orthopedics, neurosurgery, neurology, neuroradiology, and that's where we've sometimes actually applied this RAND criteria of appropriateness. And I think it's incredibly valuable to have multiple perspectives. I think the prototypical example is with tumors, right? You really can't provide appropriate care for tumors. We talked about this with the Mayo cases on Tuesday. You can't provide appropriate care for patients with tumors without an interdisciplinary group. And I think for spine as well, I think it could be very valuable. I'm not sure the model that's been presented by Raj and the Seattle Spine Foundation really applies to what we're doing, and that those were really cases that were done for low back pain, fusions for low back pain, and we're not doing a whole lot of that. Those probably would be assessed as being inappropriate in a lot of those cases. So to suggest that more than half of the cases are inappropriate, I think is a selection bias of the cases that they're looking at. But having said this, I think there's tremendous value to the wisdom of crowd and to peer review. Rick, when you say you've got a actual peer review committee, what's the teeth of that committee? Do you ever say, hey, this case is coming up in a month and it's not going to get done?
Well, Sig, I think the important thing is the timing. And I know Rothman does something similar to what you do, meaning they review all the case on Monday. But if you see a case that shouldn't be done, are you going to say, okay, you can't do that case this afternoon, you can't do it on Tuesday? So we do have teeth. I admit that the most of the cases we do end up approving, but we'll make suggestions. Or, for example, if it's a patient that was presented with cervical myelopathy and they want to do, multiple levels, and we say, this level level really doesn't look like there's significant stenosis. Have you done this? Have you done that? We might suggest changing levels, or sometimes, and using the myelopathy as an example, say, this stenosis really doesn't look that bad. Are you sure that you've looked at everything? So, it is helpful. And these cases are reviewed before they're actually scheduled. Okay, so they're not emergency cases, and tumor's a totally different story. As you say, you have the tumor board, and Izzy's involved with a lot of that.
So one of the things I'm concerned about is when we look at just the x-rays and the history, and we don't actually sit with the patient. It's the experience of sitting with the patient that puts the patient front and center. And it's the patient's preference, the patient's risk profile that I think's really got to be part of the consideration. And that's where sometimes I think multidisciplinary panels need to be a bit moderate in their recommendations. And ultimately, again, it's the patient and the physician who've got the stake in the game. Let's transition, because we don't have much time left, but there's two more papers on healthcare alternative payment models, one on bundled payments and one on alternative care organizations, or accountable care organizations. And Shane Birch, who's my partner here at UCSF, Shane's going to moderate the next two papers. The first one will be Mike Venezia. So Mike's finishing his fellowship with us. He's going back to Tampa, Florida for his practice. So Mike, why don't you go ahead and take this over, and Shane will moderate the discussion on bundled payments.
Great. Sounds good. Thanks, Dr. Berven. So, my paper is Brooke Martin's paper on the early effects of Medicare bundled payments for care improvement programs for lumbar fusions. So as a bit of a means of introduction, as we're all aware of the Affordable Care Act that was instituted in 2003, and this provided and included in alternative payment models, one of those being the bundled payment, the BPCI program. So this was a piloted episode-based program that bundled payments, setting a predetermined reimbursement for all services related to a specific targeted diagnosis. Now, this differentiated from hospital-based DRG reimbursements in a fee-for-service system, as it also included post-acute care as well as professional fees. The goals of these were to foster joint accountability among the providers and hospitals, as well as coordinate care and eliminate certain unnecessary services while streamlining efficiencies and improve the quality overall, including the reduction of admissions as well as reoperations or adverse outcomes. One of the notions is that it tended to favor high volume institutions that had the capabilities to institute these, as well as absorb the financial risk that may be affected by the initial implementation. And that this may affect academic centers negatively as they do larger cases. So the Center for Medicare and Medicaid Innovation, they initially offered 4 voluntary payment models, and we're going to focus on Model 2. There was one for nursing homes as well. So Model 2 included reimbursements through a defined post-acute period, which was selected by the hospital themselves, substitute or to a specific triggering event, which would be the equivalent of a DRG. And this had the largest enrollment. There was 48 specific clinical triggering events defined by a DRG, and the select duration, be it 30, 60, or 90 days. And this is kind of a chart of the models. We're going to focus on Model 2, which included inpatient admission for that selected DRG, and it had related ambulatory skilled nursing home as well as professional fees bundled into that. So for this study, it was a retrospective analysis of the 2012 and 2013 Medicare claims of the bundle payment program that focused on, this paper focused on the bundle for lumbar fusion. The specific DRG it used was non-cervical spinal fusion, which is a very non-specific DRG, as we all are aware. And this was in 2012 and 2013. They excluded spinal fracture, spinal cord injuries, and any sort of tumors. And they looked to identify claims level data at a claims level database that included DRG, the dates of service, as well as the payment amounts and the CPT codes. So they looked at differences in patient and hospital characteristics, and they compared the changes in the procedure volume of fusions performed at those institutions, as well as 90-day episode of care and cost, as well as surgical safety after the program was initiated. It was kind of sub-stratified into preparatory and risk-bearing, the difference being that the preparatories entered the BPCI program, but they were not subject to the financial risk of it, and the risk-bearing hospitals were actually subject to it. There was a bit of an overlap as data collected prior to October 1st at the risk institutions were not at financial risk, so they were pseudo in the preparatory stage, and the reoperations were limited to the lumbar spine itself. For the results, there was just over 2,000 hospitals that provided these trigger cases. 32% of them participated in the BPCI preparatory program, and just about 5% of them at 102 participated in the risk-bearing program. Almost all of them selected the 90-day bundle, and they found that the hospitals that chose to participate, be it 37.7% or so, had larger procedure volume, greater bed counts, as well as more discharges. After all the exclusions, they found a total of 52,000 patients in 2013 that underwent lumbar fusions, and there's some of the data here for that. The distribution was similar between the fee-for-service as well as the BPCI groups. This is a chart looking at the actual fusion volumes. There was a bit of an increase at around this number is actually wrong, about 3.4% in the risk bearing. This barely reached statistical significance. And then looking at some of the results, particularly the 90-day episode of care, the finding was that hospital participation in the BPCI did not significantly reduce the cost of care among lumbar fusions. If you look, it actually the percent change was the lowest among the risk bearing there. Things they also looked at was all-cause readmission, and then even after adjusting for age, sex, race, comorbidities, and hospital size, repeat spine surgery and all-cause readmission rates did increase from 2012 to 2013 among the risk-bearing hospitals comparatively. They found no difference between rates of device complications, wound problems, or life-threatening complications between the three different participants. So compared to non-participant hospitals, risk-bearing hospitals, they failed to achieve cost reduction similar to that of preparatory and non-preparatory hospitals. Between 2012 and 2013, there was a slightly increased procedural volume and readmission, as well as repeat surgery rates among the risk-bearing hospitals. So early data may suggest that there was an increase in reoperation readmission rates without any evidence of cost reduction. For means of time, we'll just kind of go through some of the take-home points that these hospitals that voluntarily participated in the bundle payment program were tended to be larger in terms of the procedural volume and total discharges, and they had higher episode costs preceding the year, which could affect some of those numbers. And these risk-bearing hospitals slightly increased their fusion volume as well as their 90-day readmission rate and repeat surgery rates, while failing to reduce costs. So the early findings suggest that possibly an unintended and potentially harmful effect of these BPCI programs. Although it is too early to tell, I think some of the limitations of the study is just looking at 1 year of data. We kind of need a little bit more long-term study to show that, as well as kind of get a better granularity on the data. I'll open it up for discussion, though.
Yeah, thanks, Mike. I think that this paper and the next one kind of speak to our inability as spine surgeons to develop clear-cut algorithms, and it's in part because the complexity of what we do is determined by the number of levels that are involved with the patient, its pathology, the different diagnoses that come into play, and obviously the different treatment options. And it's hard to develop algorithms that fit nice and neatly into these algorithms that would fit into a bundled payment plan. So we can open it up to the floor for a quick discussion before we move on to the next paper.
So at TBI, we jumped into the BPCI program early on, and we were very enthusiastic and rigorous about it. We hired extra staff to take on the program and monitor. And we learned very early on that the issue was downstream control. We could not control what was going on at the various rehab centers. We tried, we had liaisons, but that really affected our bundles and essentially necessitated us backing out of the program.
Yeah, there's a lot of pieces that don't necessarily talk to each other just yet.
Similarly, at UCSF, when we looked, we modeled some bundles in arthroplasty. At least 50% of costs were after discharge from the hospital. And I think in the absence of owning your own rehabilitation center, it's really difficult to control some of those costs.
Hey, Sig, where do you think predictive analytics and AI is going to help?
A great question, Rick. And I definitely think in terms of identifying a subset of patients who are outliers. So as you know, I presented an abstract on that. I think you and I talked about this, but we did an abstract looking at machine learning for predictors of outliers. And we had 15% of our cases who underwent multi-level fusions who were outliers, meaning they were 1 standard deviation beyond where the bundle would have paid. And in that instance, some of the factors included patient factors, so significant comorbidities, and also multi-level surgeries. And the diagnosis, the tumor patients were much more expensive than the degenerative patients. So I think recognizing, using predictive modeling, who are going to be the outliers would really allow us to minimize the risk of participating in the bundle and just define more clearly a homogeneous group of patients that are more appropriate to include in a bundle, and a group of patients who really ought to be left out of a bundle because there's too much risk for an outlier.
Thanks.
Okay. So should we go on to the next paper? Kevin, are you ready?
Yeah, I just need control of the screen here.
Yeah, Kevin's going to present about accountable care organizations and another important model for sharing risk, and another important alternative payment that may influence quality of care.
Would you mind bringing up the presentation from your computer, Dr.?
Sure.
Okay, thank you so much.
Yeah, no problem.
Kevin, you got it there? You can share your screen.
I do, yeah. I'm getting it up for you. There it is. Alrighty. Can everybody see that? Are you able to see the...
No.
Oh, Kevin,
Blank
we can't see
screen.
the...
You can see that.
Okay, there we go. We'll just present it this way. So I'll be talking about alterations in 90-day morbidity, mortality, and readmission rates following spine surgery in Medicare accountable care organizations from 2009 to 2014. The first author was Schoenfeld, and primary author was James Kang. So as a background, Dr. Berven already touched on this earlier, but this study looks at accountable care organizations, and to review an ACO, they consist of groups of doctors, hospitals, and other healthcare providers who come together voluntarily to give coordinated, high-quality care to their Medicare patients. The goal of coordinated care is to ensure that patients get the right care at the right time while avoiding unnecessary duplication of services and preventing medical errors. When an ACO succeeds both in delivering high-quality care and spending healthcare dollars more wisely, the theory is that the ACO will share in the savings it achieves for the Medicare program. And that was the CMS.gov definition. So ACOs were implemented as part of the Accountable Care Act with three primary goals, which were enhanced access to healthcare, improved quality, and reduce costs. Advocates stated that ACOs would provide increased efficiency and would reduce unnecessary procedures and tests, resulting in savings to the healthcare system and improved care. As ACOs were designed with the intent of improving quality and impacting costs through increased surveillance and coordination of care, many efforts were focused at the primary care level. However, with surgical procedures, they weren't really considered, and they were more secondary, if considered at all. So there were some early papers out there, and the early evidence indicated that the ACOs have been successful in reducing overall healthcare costs and implementing some preventative care measures. However, their impact on quality...
Kevin, the slides are not advancing.
Yeah, I'm...
You're still stuck. We're still stuck in your title slide. You can keep talking, but I just want to let you know that that wasn't happening.
Oh, okay. Thank you. Yeah, I don't know what's going on, but I'll just keep going. So So the impact of these ACOs on quality and outcomes such as morbidity, mortality, and readmissions has not been substantially investigated following surgery. So in this study, they looked at national Medicare claims data for a period overlapping the implementation of the ACA from 2009 to 2014 to evaluate the impact of ACO formation on outcomes in the 90-day period following spine surgery, including in-hospital mortality, complications, and readmissions. And the hypothesis was that post-surgical morbidity and mortality as well as readmissions would be lower among Medicare beneficiaries treated in ACOs as compared to non-ACOs. So this was a retrospective review of national Medicare claims data for patients who underwent lumbar interbody fusion, posterior lateral fusion, decompression, or discectomy between January 1st, 2009 and December 31st, 2014. All the patients were 65 or older. There were 344,813 patients included in the analysis. And 97% of these patients, or roughly 330,000 of them, were in non-ACOs, and 12,000 of them, which accounted for roughly 3%, were treated in ACOs. The primary outcomes that they measured included post-surgical complications and readmissions at 90 days following surgery. In-hospital mortality and 30-day outcomes were secondary outcomes. And they used a multivariable logistic regression analysis to adjust for confounders and determine the independent effect of ACO enrollment on post-surgical outcomes. Oh, there you go.
Advance by clicking on that bottom left there.
Yeah. Seems to be working now. I'll catch everybody up here. All right. So we're getting to the good part anyway. So table one, this basically looked at demographic data between the cohorts, and this was similar between both groups. Then in table two, this looked at the adjusted odds of in-hospital mortality, 30-day complications, and 30-day readmissions in ACOs and non-ACOs between 2009 and 2014. ACOs in 2012 to 2014 demonstrated a 16% increase in the odds of complications versus non-ACOs, which you can see on this line here. However, there was no significant increase in the odds of readmission. In table three, this again showed similar findings, and this looked at the adjusted odds of 90-day complications and readmissions, again in ACOs and non-ACO environments between 2009 and 2014. And ACOs in 2012 to 2014 found to have an 18% increase in the odds of complications and a 14% increase in the odds of readmission as opposed to non-ACO environments. Non-ACOs in 2012 to 2014 actually showed modest reductions in the odds of complications and readmissions as compared to the period from 2009 to 2011. And then finally, in table four, this looked at demographic and clinical characteristics associated with the occurrence of complications and readmissions at 90 days following spine surgery in the total cohort. And they found that patient age, male sex, comorbidity score, and surgery at a teaching hospital were all associated with a slight increase in the odds of complications and readmissions in ACOs. So this study was thorough, although it did have some limitations. It was a large database study, so claims data and ICD-9 coding were used to identify patients eligible for inclusion in the study, so there's potential for coding errors. Again, large database study, so there's lack of granularity of the data, so things such as rationale for readmission, indications for surgery, and radiographic results weren't available for review. There was no functional outcome data included with so many patients in the study, and the results may not be translatable to patients less than 65 years old, the non-Medicare ACOs, and non-lumbar procedures. So the authors concluded that Medicare data from 2009 to 2014 failed to demonstrate superior reductions in postoperative morbidity, mortality, and readmissions for beneficiaries treated in ACOs compared to non-ACOs. And the mere participation of an organization in an ACO should not be expected to translate into superior postoperative outcomes following spine surgery. So, sorry about that, the technical errors, but that's the study.
Well, thanks, Kevin. So what's your take on why the ACOs didn't demonstrate an improvement?
Well, I think some people have touched on it. There's so many moving parts to it. And I don't know if, like the study concluded, just a participation of an institution in an accountable care organization will not necessarily provide for improved care. Ultimately, it's up to the physician and how attentive they are to the patient's care. I don't know if necessarily just being involved in these accountable care organizations is going to change everybody's practice. You can change your individual actions, but I think it takes a large effort to make sure everybody's on the same page with the common goal. And with so many moving parts, I think that can be difficult.
Yes, I'm curious, who on the panel is actually participating in an accountable care organization reimbursement program? Specifically at UCSF, we've got about 140,000 lives that are covered by an ACO, but it's largely blinded to the provider. And what I mean by that is that I don't know that a patient's health care is being provided by an accountable care organization. But the reimbursement to the hospital, the risk to the hospital is very different under an ACO than it is in a fee-for-service program. But it's largely blinded to me as a provider, which is probably appropriate because we don't want to necessarily be treating those patients differentially. But who else is participating in an ACO reimbursement system, and how does that change your ordering tests or your considerations with regard to costs?
What's he going to do today?
So it sounds like the penetration of this in Seattle and Texas and other areas might be a bit limited right now. To that end, I think we're going to see more of this. This is Bob Kaplan wrote about this as an important change with regard to providing care, and the notion of having a capitated amount of money to care for the total medical needs of the patient over a period of time, I think would significantly change perhaps how we might consider some of the more expensive interventions that we might otherwise consider. Shane, any other comments you want to wrap up with?
No, I think that was well put. I don't have any other comments.
Thank you guys, Sig, Shane, and the crew. Great job. Really good, interesting papers and good discussion. Thanks.
Yes, thanks to USF. You guys are great. Take care. Great weekend.
Have a good weekend, everyone.
Okay, thanks, everybody. Have a great weekend.
Thanks, Sig.
Thanks for watching. Hit the subscribe button for more medical content.